So, good evening, everyone. Are you able to hear me? I'm having trouble sharing. I don't know what to do. Let me just get in touch with Joe. And I'm not sure if you're able to hear me over the microphone. So I don't know if you're able to see my screen now.
Hi, yes, we can see your screen.
Yeah, okay. Thank you. So I'm so sorry for this. I have really worked hard to maneuver and get my way through this, but I'm really sorry. I'll try my best to go through this as fast as we can so that we are within the time frame. So yeah, today we are going to do introduction to MSK point of care. And in this, we are going to cover a few things that point of care actually entails. And the target regions that we usually try and cover is that we want to check like the upper limb, the lower limb, and all that. But then there are so many aspects of this, and the clinical relevance is usually mostly in sports medicine and people who present in the department with emergencies. And so for today, we are going to start with asking ourselves, what is MSK point of care ultrasound? And in this case, it is evaluation that is one real-time ultrasound imaging that is performed at bedside or clinic or in a field when the sports people are playing and all that. And it is majorly to assess the muscles, the tendons, the ligaments, and the joints, and the soft tissues. And why do we do MSK POCUS? And usually it is for rapid diagnosis of injuries, and it is non-invasive. As we all know, ultrasound is non-invasive. You can use it dynamically, and dynamic to mean that, like, for example, when we are testing for impingement, you have to do the dynamic maneuvers, which are not possible, of course, in an MRI where you have to sit still or to stay still to be able to image a specific part. And of course, it is portable, and it enhances clinical decision-making in sports rehabilitation. That would be one, to make a quick diagnosis. Two is even to monitor healing. Like if, of course, there was, let's say, a full thickness tear and all that, then over time, you're able to monitor if it is healing properly or not without necessarily sending for another MRI. And therefore, ultrasound is of course, a very powerful tool. And of course, also, it helps in guiding PRP injections. And why do we do this in sports medicine? We've said that it detects tendinopathy, and tendinopathy can range from tendinitis, tendinosis, and we'll be able to talk about the difference between those. Tears, ligament injuries, and effusions, like knee effusions and the rest. Then it guides rehabilitation progress, as we've said, and return to play decisions. And then reduces reliance on MRI for common conditions, because there are so many MRIs that could be avoided. They may not even be necessary when you use an ultrasound to be able to do your quick diagnosis. Then we have, it enables dynamic assessment, as we've said, during movement, and it is used by orthopedic doctors for ultrasound guided procedures, and not only orthopedic doctors, even physicians who work with people who are sportsmen, because we will find them in our departments when they come for their checkups. So the target regions that we usually do in a complete MSK POCUS training is that we do the shoulder, that is to check the rotator cuff, the biceps tendon, the subacromial bursa. In the elbow, we want to check, of course, the golfer's elbow, which would be, more medial injuries. And then we have the tennis, and that would be the flexor and the extensors. We also have wrist and hand, and we have carpal tunnel syndrome. We also want to check some of the tendons along the wrist and even the carpal bones themselves. And in the lower limb, we would be looking at the hip and the groin region, that is the iliopsoas muscles, the adductor muscles. We'd be looking at the knee, that is, we focus on the quadriceps tendon. We have meniscal assessment, whether there is extrusion or not, and effusions. Then we have ankle and foot, where we'll be checking the Achilles and the plantar fascia ligament. And for today's lecture, we will be focusing at the Achilles tendon and the plantar fascia, because those are the most common injuries that would be, most athletes would actually present in the department. So the commonly, the most people who actually injure their Achilles tendon are runners and people who are very active, like those who go to the gym, those who run, those who exercise a lot and all that. In most cases, those are the sportsmen generally. And there's a high prevalence, of course, in sports-related injuries as opposed to someone who is not a sports person. And of course, our learning goal today is to demonstrate the basics of scanning those two structures, so that you understand the value of MSK POCUS, because in a classroom like this, we will not be able to exhaust all those points, but we will be able to just talk about the Achilles today and extend it to the plantar fascia. So let's move forward, and we start with the Achilles tendon. And in this case, we have the anatomy review where we will start from. And the Achilles is usually a thick tendon that is located in the back of the leg, and it connects the gastrocnemius and the soleus muscle in the calf to an insertion point at the calcaneus. And the calcaneus, of course, is what we know is known as the heel bone. And it is the strongest tendon in the body and allows people to push off while walking and running and also jumping. And as you can see there, we have the image there. That is the gastrocnemius muscle. You can see them. And then the thin muscles at the sides there, that is the soleus muscle. Then we have the Achilles tendon there that appears as a white image there. Just after the muscle, which is brown, we have the white part, and that would be the Achilles. And as you can see, it is very long. That is on the gross anatomy. When you check on the next image here, the ultrasound image here, this is like a continuation of the same Achilles, but this is the soleus here. We have the Achilles tendon. You can see this bright echogenic tissue here that looks like it has lines in between. And those lines are usually what we refer to as fibrillar pattern. In any tendon, all the tendons in the body have the same similar pattern. And that is what is known as fibrillar pattern. There are parallel lines that run through that. And you can see it's continuing all the way until it inserts at the calcaneus. And where the yellow arrows are actually binding, that is the Achilles tendon. That is how it appears on ultrasound. So the Achilles injuries can occur in several places, but the most common area that it occurs is what is known as the muscle tendon junction, or what is known as the myotendinous junction. And that is the area where the calf muscles join to the tendon. So that is the junction where we usually get a lot of tears. And this junction has smaller blood supply than does the muscular area of the leg. However, this makes the healing process also slower in many other leg injuries because of that blood supply. Remember, the blood supply usually would bring, all the nutrients, all the phagocytes and everything else that is engaged in repair as well. But in this case, then the blood supply is very little, and therefore that is why it takes time to heal. So then we have, how do we scan the Achilles tendon? Because apart from just knowing, then you need to know how to be able to scan it. And usually the technique is that you have to position the patient on prone. They lie on their tummy, and the feet are hanging off the table. And the transducer, I'm sure you must have learned already about the physics, which is the different types of probes. And in this case, we are using a linear high frequency probe that is between 10 to 18 megahertz. And because the Achilles tendon is usually very superficial. And the views that we use in ultrasound all the time, we always say you have to use both planes, which is the longitudinal plane, also known as the sagittal. And in this case, what would you be assessing? You'll be assessing the fibrillar pattern, and you'll also be measuring the thickness, and you also want to check the continuity. These parallel lines, they should be no break in between. And then, of course, for the axial, you want to check the cross-sectional shape of it, how it looks like. And usually there is that peritendinous envelope. And when there is a problem in the tendon itself, it can actually collect some fluid around it. And this fluid, you can be able to see it better on a transverse plane than on longitudinal plane. So then we have, in a prone position, let the leg, the foot hang outside the edge of the examination table. And or with the toes lying over it, that is stretching. And look clinically to the position of the foot, comparing both sides, because in most cases, actually, when there is an Achilles tear, you'll be able to see the difference between the other one and if you're not sure, you place the probe and you place the probe on the other side and compare and see, do they look the same? So when you compare both sides to see any differences that can lead to the diagnosis of either Achilles tendon full thickness tear, or even if it is partial tear, you can be able to compare the two. And then we have, you examine the Achilles tendon from its myotendinous junction, that's what we've said, to the calcaneus insertion. You have to follow it by means of transverse and longitudinal planes. You don't just do it like and stop in the middle. You have to start all the way from where it is originating from up to its insertion. So while imaging the Achilles tendon on the short axis, you need to tilt the probe, as I said, to each side. It's like you're rocking the probe from side to side as you go down. And by now, I believe that you already know what a longitudinal plane and a transverse plane would be. The longitudinal plane is where the pointer of the transducer would be pointing towards the head of the patient. The transverse is where it is at 90, you turn your probe at 90 and it would be pointing towards the patient's right or towards you if you're right-handed. So in that case, while you're scanning the transverse plane, you need to rock from side to side. Like as you scan down, you also need to be scanning on the sides to assess the peritendinous envelope, and that's what we talked about. Also, remember, even when there are no tears, for example, in the tendon, there could be inflammation, like tendinitis. There is inflammation of that tendon, and when there is inflammation, of course, there will be fluid that is collecting around, and the patient could actually present with pain. And then you measure the size of the Achilles tendon only on the transverse plane. And the Achilles tendon has to be followed down to its calcaneus insertion. Check the retro-Achilles and the retrocalcaneal bursa. And of course, all bursas are usually just above the tendon itself. Yeah, and you check both the bursa and you also check at the tendon sheath, which would be closer to the bone. Just between the bone and the tendon, there'll be that sheath there, and that is also where fluid could collect. So this is how the leg would be positioned, as you can see that. And what is labeled there as A is actually the longitudinal plane. You can see it is pointing towards the patient's head. And the transverse is B. That is when you turn your probe to 90 degrees to face you. And that would be the transverse plane. So as you can see here, from this image that is above here, this is a longitudinal view. And you can see the arrows, the white arrows there. That is all the way from, it's starting from the origin, from the gastrocnemius, and it comes all the way until it inserts at the calcaneus. And there's this place here which is labeled as a star. And usually in tendons, when you are scanning tendons, there is a common artifact, a very common artifact that is known as anisotropy. And anisotropy, how you tell that this is fluid and not anisotropy, or it is anisotropy, is that when you change the angulation of your probe, it would disappear. Then that would tell you that was just an artifact. But if it persists even from all angles, when you keep changing your probes from, changing the angle, and it persists, then this could be tenosynovitis, because the fluid would actually collect at the point of insertion. So in this case here, this was anisotropy, and I just wanted to explain what anisotropy and tenosynovitis would look like, because when fluid collects there, then that means there is some inflammation. But when you change the position of the probe and this dark area disappears, then that was an artifact, and that artifact is called anisotropy. So as you can see here in this image, we have the Achilles tendon there, and we have a pad usually between like bone and another muscle. Like in this case, we have what is known as the Kegas fat pad here. And just below the Kegas fat pad, we have the flexor hallucis longus. That would be the muscle just beneath it. But the fat pad usually is just for, insulation and all that. But that is, the Achilles tendon is where you can see the white arrows there. And that is on a sagittal or longitudinal plane, which would be this plane that is labeled as A. then this image here, down here, you can see this is now the transverse of it. It's like you're cutting across. Maybe you pick this part, you cut across, or this part, or this part, or this part. And that is why we scan through as we go, because you want to see that there is no fluid collecting on the peritendinous envelope. So this is how the tendon would look like on a transverse plane. So usually for the Achilles tendon, there is also another very thin tendon that is below it, and it is a variant. Not everybody has it, but for those who have it, it is known as the plantaris tendon. And sometimes when there is a full thickness tear of the Achilles tendon, sometimes you can see another tendon that is, running down, and you might actually think it's a remnant. You might think it is like partial tear thickness of the Achilles tendon. But then when you follow it all through, you can see that it is actually very long, and it is also attaching. It has an origin and an attachment as well. So that would be actually the plantaris, but that one is a variant. So dynamic imaging during passive or dorsal plantar flexion helps to distinguish between the partial and complete Achilles tendon tears. In most cases, when there is a complete tear, then you will not be able to do those maneuvers, the plantar flexion and those dynamic maneuvers. You cannot be able to do it. So the Achilles tendon conditions and issues, having seen how the normal tendon would look like, then in chronic or long-lasting Achilles tendon disorders, they range from overuse injuries that cause inflammation or degeneration, to acute traumas such as Achilles tendon rupture, which could either be complete or incomplete. So pain along the back of the ankle or the heel are often the result of distinct problems along the course of the Achilles tendon, or at its insertion point, at its attachment, or the plantar fascia as a referred pain, because some of them could be feeling pain. They could tell you, I'm feeling pain around this area, like vaguely. They would give you the heel. Sometimes it's extending to the back of the leg. That would be like the posterior part of the ankle. And that is why in most cases when we are assessing the Achilles tendon, we don't do it alone in isolation. You have to do it and push your probe further to be able to check the plantar fascia. So pain along the back of the ankle or at its heel are often a result of distinct problems along the course of the Achilles. And this type of pain may also be caused by retrocalcaneal bursitis, which is sometimes called as Achilles tendon bursitis. And bursitis, in most cases, would appear as fluid collection at the point of insertion. Like now in the calcaneal, attachment, you might actually see some fluid collection there, and that could be Achilles tendon bursitis. So then we have, what are some of the pathologies that we have? The spectrum of tears range from micro tears to interstitial tears, which are known as intersubstance tears, and they are parallel to the long axis of the Achilles itself, to partial tears, and eventually to complete tears. So the intersubstance tears, in most cases, they would actually even run parallel like with the tendons themselves, but then you find that there are micro tears in between. And tears can be acute, and they can also be chronic with repeated microtrauma. And that microtrauma over time might end up now aggravating up to complete tears or complete tendon rupture. And the mildest end of the spectrum is the micro tears, of course, and the other extreme would be a full thickness tear. So the location, typically in young individuals with a normal Achilles tendon, the rupture will happen at the critical zone, which we've said, and this is a region which is relatively hypovascular, and it is usually about 6 centimeters proximal to the insertion from the Achilles, that is at the myotendinous junction. That, depending on the age of the patient, that is how it would you could actually find those tears around that part. Then for partial thickness tears, there is often enlargement of the tendon, which is more than 1 centimeter, So maybe the question would be, what would be the normal thickness? It should be around 6 millimeters. It's usually 4 to 6 millimeters. So once it goes beyond 10 millimeters, which is 1 centimeter, then with abnormal hypoechoic and echoic areas within the corresponding part, or the tear where there is tear, and that would be associated, that could be, you could associate it with tendinosis. And I want to explain the difference between tendinitis and tendinosis. So tendinitis, in most cases, the tendon would be thickened as opposed to really being heterogeneous. So I don't know if you had, I believe you had learned earlier on about the terminologies that we use in ultrasound. When we talk about hyperechoic, hypoechoic, isoechoic, could someone probably just confirm to me if you've heard that lecture before? Anyone?
Yes, we did.
Okay, thank you. So what usually in tendinosis, what usually happens is that it would appear heterogeneous. That would be a mixture of hyperechoic and hypoechoic. But in tendinitis, which is the inflammation, in most cases it would just appear hypoechoic because the tendons naturally are hyperechoic. So they start becoming hypoechoic and it is thickened. And when you put color Doppler, it would be hypervascularized. It would appear to have more vascularity than the normal. And how do you tell that what is normal and what is abnormal? You compare with the adjacent Achilles tendon. The other one that is not injured, you put your probe there, you put color, you see the kind of vascularity it has. Then the one that you suspect could be having tendinitis, and it would have associated peritendinous fluid, then that one, you would be able to pick, the color would be much more, and that is hypervascularity. So that is how you'd be able to tell that this is tendinitis. But tendinosis would actually be heterogeneous, and it would have that mixed echogenicities. And why it looks like that is because of the micro tears that have been tearing over time. Then we have you can see here from this image, we have the asymptomatic Achilles tendon. This is a normal one. You can see it has the normal fibrillar pattern. This is the calcaneal insertion. It has that fibrillar pattern there. But then the next image that we will see, you can see that there is some discontinuity, yeah, at this point. But at this point, it is still preserved. You can see that the tendon here is actually preserved. Just a minute. Yeah, so we would have, sorry for that, sorry for the interruption. So we would have, you can see here, if we go back to the previous image here, you can see this is a continuous fibrillar pattern from that Achilles. But then the next image here, you can see around this area, there is actually discontinuity, and that part is where there is a tear, and you can see even the tendon itself has completely retracted from the origin, because this is the calcaneus here where it is inserting. But you can see all this other part is actually preserved. But here there is a discontinuity, that parallel. And remember, we said the longitudinal view would be able to tell you when there is also discontinuity. Sometimes this is actually a full thickness tear, but sometimes when it is not complete like this, you'd actually see maybe a micro tear or a tear that comes up to the midway there, and you'll still see some dark area, which would be hypoechoic as compared to the adjacent tissues, which in this case would be hyperechoic for the tendon. And you can see here as well, this is another type of, this is the Achilles tendon, but you can see it has some things like calcification, and this could actually be a chronic disease of some sort, so that each time the body is trying to repair this tendon, then it forms scarring, which in most cases would appear as they look like calcifications. Then we have another image here, which this would actually be, you can see this is at the insertion point, and you can see there is some fluid collection there. And that is retrocalcaneal bursitis, because you can see the fluid is collecting there. And when you put color, anytime you get something that is like bursitis, tenosynovitis, and all that, then that would mean that there is inflammation. So you can see how color Doppler is actually useful. And just as I said, if you're not sure if there is hypervascularity, you have to compare with the other one, the normal one. Just put the same at the same level where you're putting your probe. Just confirm with the other one if they look alike, and put your color so that you can be able to tell when there is inflammation. Then we have Achilles tendon anatomy and pathology quiz that I want us to discuss a little bit and see if you've been able to pick at least one or two things, because this is just an overview scan whereby, because you can, all tendons, as I said, they actually look alike. If you get to any tendon in any part of the body, they all are the same. They would have that the fibrillar pattern. They would be hypoechoic. They would be hyperechoic. Sorry, and anytime you see that hypoechoic appearance, it could either be anisotropy, or it could be inflammation, or maybe some chronic kind of disorder in that tendon. And how you tell the difference is when you are able to change your angulation. So the first question here I want to ask is, which transducer is the most appropriate for imaging the Achilles tendon, and why? Somebody could try.
If I can just go, I think your answer would be B. So because the Achilles tendon is superficial, you want one with a higher frequency, so the 7 to 15.
Yeah, thank you for that. So anytime that you find a probe that is low frequency like this, that is a curvilinear, the convex probe, it means it goes deeper. It penetrates more deeper. The higher the frequency, the more, the less the penetration. But when the frequency is lower, then when the frequency is higher, the penetration is also lower. So that is correct. So to question 2, which ultrasound artifact is commonly seen on the Achilles tendon due to its fibrillar structure? Maybe BB can try. Or Johanna. Or a volunteer then. Someone can volunteer. Maybe Radia, you can try again.
I'm not actually sure. I know we were talking about anisotropy as a common artifact, but I'm not sure for this one.
Yeah, actually, for the tendons, there is no other artifact apart from anisotropy.
Okay.
And anisotropy in MSK is the common artifact, and it appears like a dark shadow along the tendon that you could, or even at the insertion, that you could actually think it's inflammation. But how you tell that this was an artifact and it is not inflammation is that when you change the angle at which you're approaching the tendon, anisotropy in most cases would disappear. When you actually parallel, when you're exactly parallel with the tendon, anisotropy will disappear. When you're like off from it, then it will appear again. But how do you tell the difference between anisotropy and fluid collection, in this case, which would also be hypoechoic? Then you change the angulation. So anisotropy is the most common artifact, and when you'll go for your practicals, you'll be able to see that when you, and sometimes actually anisotropy is I would say, especially when we are scanning like the wrist, or even the ankle. We want that anisotropy so that we're able to differentiate between the nerve and the tendon itself, because sometimes they are so close that you can't tell. Remember, the nerve would look like honeycomb, or it would look fascicular, and sometimes they appear almost it's the same thing. But then you angulate your probe so that you create anisotropy. Then you can be able to tell which one is the tendon and which one is the nerve, because the nerve will not have anisotropy. And the reason there is anisotropy is because of the fibrillar pattern. The nerves do not have that fibrillar pattern like the tendons. So then the next question is, when scanning the Achilles tendon, the patient is best positioned in which position?
I think it's in a prone position, foot hanging over the edge.
Yes, that is good. So that you're able to compare, even visualizing, when you just check, you can be able to see, you can actually see an Achilles tendon that is ruptured even by just checking without even putting the probe, because they would appear different. You will see that, and they are not able to do the dorsiflexion, because that is what should be helping them. So then we also have another question here, which a hypoechoic focal defect with tendon discontinuity and retracted ends in the Achilles tendon would suggest what? Hypoechoic focal defect with tendon discontinuity and retracted ends. That should give you the answer.
I think this one is a complete rupture.
Yeah, good. That is actually a complete rupture, because there would be no retraction when there is partial tear. Yeah, that was good. Then we have a patient presents with posterior ankle pain after a sudden pop while running. Ultrasound shows loss of fibrillar pattern, hypoechoic gap, and the Kega's fat pad is bulging. The most likely diagnosis in this case would be what? What do you think? Just give it a try. Someone? Johanna, you can try again. Okay, maybe I can take that up. Of course, this would still be a complete Achilles rupture, yeah? Because in most cases, when there is that pop, like it snaps, then it means it has detached from point or at the myotendinous junction. Yeah, so that would suggest complete tear. So then we have our last question here, which is a hypoechoic focal defect with tendon discontinuity and retracted ends in the Achilles tendon would suggest what again? I think that's a repetition. It would actually be a complete rupture. Then the last question here is, which Doppler finding is most common associated with chronic Achilles tendinopathy? Chronic Achilles tendinopathy. What would be the Doppler finding?
I think for this one, it's B, the increased neovascularity, I think.
Okay, so in this case, well, thank you for the try, but when there is chronic Achilles tendinopathy, there is usually no flow. When there is flow and you can see there is blood flow, that would be an acute process because it is inflammatory. Remember, what we are checking here is that there is a lot of blood supply to that area to try and fight it. But anything that has been chronic, in most cases, there will be no flow. Okay.
Sorry, can I just ask you to repeat? So you're saying that in an acute case, there's increased,
Yeah.
but if it's chronic,
Yeah.
then there's no flow.
Yeah, either
Okay.
no flow or
Thank you.
very minimal flow. Yeah.
Okay, thank you.
Yeah. So then let's move on to the plantar fascia. And the plantar fascia, of course, you know, is at the sole, which supports the medial arc of the foot. And plantar fasciitis is common in runners as well and in overweight individuals. And that's why I said some of these patients will present with pain that they'll tell you, I just have pain at the back of my leg. They can't tell exactly or pinpoint exactly where, unless, of course, there is that complete or partial tear. That one would be more specific. But then sometimes when there is inflammation, it could be pain from the calcaneus, it could be pain from the plantar fascia. So you may not be able to tell, is it plantar fasciitis or is it Achilles or retrocalcaneal bursitis. So that is why you also need to understand and see that when you're doing your Achilles, you need to push your probe further down so that you can be able to check the plantar fascia. And plantar fasciitis, we've said, is common, of course, in runners as well, just as the Achilles tendon tears. And as you can see there, of course, the plantar fascia is here. You can see that this is the heel bone where the Achilles will have attached, but just right after it, we have, in most cases, this is where we will find that plantar fasciitis, because the plantar fascia is the entire, you know, sole of the foot there. But where there is always inflammation is actually around that area, just after at the point of insertion. And as you can see here, we have our probe here. You see where you place your probe? It is just after. It's like you've gone round the heel and you're now scanning at the bottom of it. And what you expect to see would be something like this, where this is the calcaneus here. And you can see here, we have the plantar fascia itself. This white thing here would be the plantar fascia. And here we have the flexor digitorum brevis, which would be following there. So as you can see here, the location of the structures and the position of the probe, this is where you place your probe. And of course, we've said we scan everything in ultrasound on 2 planes, but of course you'll have to start with the longitudinal plane for you to be able to identify the appearance, because the plantar fascia also almost looks like the tendon. It will have that fibrillar pattern, and it will also create an isotropy, just like the tendon itself, because it is also it's a structure that has that fibrillar pattern, and that's why it will create an isotropy. But then, of course, the plantar fascia would be much deeper than the Achilles, because there is that fat pad just before the plantar fascia. And at the plantar fascia, the structures that we will be assessing is, of course, we have to see which one is the skin, and I'll show you, and the fat pad. Then there is the plantar fascia itself, and the plantar intrinsic muscles. There are so many, there are like 10 of them. So we don't really measure a lot on the muscles, and they're also very thin. But in this case, what we want to see is the plantar fascia itself, because that is where we get a lot of inflammation. So as you can see from this image, when you put your probe at the sole there, what is labeled here as 2 will be the heel fat pad. You can see it is more thicker. What is just below it, which is labeled as 1, is the plantar fascia itself. And as you can see, it is also attaching to the calcaneal bone. Yeah, and you can see it has that fibrillar pattern. It is thin, but you can see the difference between the fat pad. It looks more hypoechoic as compared to the plantar fascia itself. And as I've said, this is at the point of insertion, and this is the fat pad. So what do you do in this case? I want someone to try. If you are doing, you are using your probe, and when you are scanning the Achilles, let's say you had set your frequency to 12. What would you likely do to be able to get your plantar fascia more closely and to be able to assess it better? Someone to try from the physics, what would you do? Anyone?
Okay, I think I'll try. I think you can maybe increase your frequency to get a better resolution.
Yeah, so you reduce, not increase, yeah?
All right.
If you are at 12, yeah, if you are at 12 while you're scanning the Achilles, for example, the Achilles is more superficial. So because the plantar fascia is deeper, we want more penetration, and therefore you will reduce your frequency probably to 9. Yeah, so that it is able to penetrate much more deeper. So you reduce the frequency if your probe actually has a way of adjusting the frequency on your screen. So plantar fascia, this appears as a distinct thick hyperechoic fibrillar band, as you've seen that, somewhat like a tendon, running parallel to the skin of the sole, and it is approximately 3 to 4 millimeters thick, measuring the thickest portion immediately after its origin. Remember now, the plantar fascia, its origin will be at the calcaneus. Yeah, so that is where the thickest portion usually is, and it usually measures 3 to 4 millimeters. And therefore, it means we talked about when there is inflammation, what happens? It thickens. So if you measure your plantar fascia at the thickest point, which is just after the origin, and you'll be able to see it, like in this case, let's go back here. You can see that this is at its insertion, at its origin, sorry, this is where it is originating from, but the thickest portion would be just after its insertion, its origin, and this thickness here should be between 3 to 4 millimeters. If you find that it is 6 millimeters, then it means likely there is plantar fasciitis because it is an inflammatory process. It has actually thickened. So you can see there this at the insertion point, that is what we usually check. And remember, the plantar fascia, as it continues, it also becomes thinner. So at the mid portion, when you have it, it would be measuring 1 to 2 millimeters, depending on now, where are you scanning, where are you measuring? But most of the time, where there is fasciitis would be just immediately after its origin. Just like we said, most of the Achilles rupture, they happen at the myotendinous junction. So for this case, for plantar fasciitis, it actually most of the time would happen just after its origin because of that, rubbing from the bone itself, and it's supporting a lot of weight and all that. So it is prone to inflammation. So most of the time where we check would be just after its origin. But if you choose to, to scan further and go down while you are at its mid portion, then it should be 1 to 2 millimeters. It should actually be reducing. So we know that as I showed you in this image here, we have the medial band, we have the lateral band, but what we usually check is actually just after its insertion there, as I had shown you. So then we continue, and we have how to place the patient, because usually in ultrasound, even the patient positioning would be important. Like, for example, when we'll be learning at a later date about, let's say, the shoulder, when you're checking the rotator cuff, how I place my hand when I'm checking the long head of the biceps tendon is not the same way I will check the subscapularis. I will actually have to rotate my elbow externally to be able to bring the fascia. You need to have the patient on their toes so that it actually stretches it out. It makes it more superficial, as opposed to if this patient had their toes, hanging, then it means it's even pushing it further because the leg is like more curved. Here we are trying to have the foot more like parallel and more straight, because remember we said when we are checking, the plantar fascia is the same as the tendon. So we want to check it as parallel as possible to the ultrasound beam. So when you're placing your probe, if the leg is not in this position, then you're not able to get that parallel, and you get a lot of you can misdiagnose because you can get a lot of anisotropy. That in that case would be destructive. But when you're not sure where are you in terms of identifying, then when you create whichever one that creates anisotropy would be the plantar fascia, because remember there are adjacent tissues. There is the fat pad here. If you're not sure, is this the fat pad or is this the plantar fascia, then you can create actually anisotropy, because it will create anisotropy. So you place the transducer, as we've said, over the plantar aspect of the hind foot, and that is where it is marked in red there. to examine the calcaneal insertion of the plantar fascia. Then the long axis of the image is obtained just medial to the midline, as you can see there. You measure the fascia at the point where it leaves the calcaneal tuberosity, and that is at its origin. The gain must be increased to avoid beam absorption by the thick plantar sole. So you can actually, you can adjust your frequency, and you can also, you can change your gains just for better visualization, because it will be much more deeper than the calcaneus. And as you can see here, if the patient is not able also to go to this, position, which would be the most ideal position, then you can have the patient lying and they rotate and flex their knee, because what we want to achieve is that we want the foot here, the sole, as parallel as possible. So overextend their toes while the foot is in this position. You can ask them to actually push their toes behind so that it is able to bring the foot as parallel as possible, because there is that medial arc. So then, of course, this is how we also check. We said we check in two planes. We have the longitudinal plane, and then you'll also have to check on the transverse plane. And how would it appear? This would be the anatomy. When you get to the, it's easier when it is the longitudinal, because there is the fat pad, and then immediately after, you can actually be able to see the plantar fascia itself, and there is a bone. And remember, bone, we said, is hyperechoic, yeah? But also in this case, you might want to check the regularity of this bone. It could be having, if it has some form of irregularity, then it means there is also some kind of inflammation, maybe osteophytes and all that, or even a spur. But then when you go to the just after the fat pad, then what follows is the plantar fascia, and you can see from the arrows there. Below it, you can see here that thing that looks heterogeneous. This would be the flexor digitorum brevis. That is a muscle. Yeah. Then we have the quadrata plantae, which is also another muscle. We have the flexor hallucis longus, which is another muscle. So you can see when you place your probe on transverse, you will see quite a lot of anatomy, but as you can see from this image, they are usually interfaces. You can see here, like the flexor hallucis longus, it looks more hyperechoic. Anytime most muscles would actually appear like this, quadrata plantae and the flexor digitorum brevis. This is how they look like. But this thin band there, you can see it is hyperechoic. That band there, that is what would be the plantar fascia when you go to the transverse. And what is our intention here? The fluid, you have to make sure you're utilizing both the longitudinal and the transverse plane. So what are the normal features that you would find on the plantar fascia? Of course, we've said it is echogenic and it is fibrillar. And echogenic is the same as hyperechoic. It is brighter than the surrounding tissue. And as you can see here, let us use this image instead. You can see here, it is the most hyper if you compare to the adjacent tissues. The fat part there looks more heterogeneous. And then we have the muscle here. It looks even darker. It is hypoechoic. But you can see the plantar fascia here looks more echogenic, which is also known as hyperechoic. So that is one of the characteristics of how it would look like. Then there should be no hypoechoic defects. And what I mean by that is the same thing, just like the Achilles. This should be running parallel. I should not be seeing anything that is hypoechoic. And if I see anything that is hypoechoic, it could be anisotropy. And how do I get rid of it? I change the angulation of my probe. If it persists, then it could mean that actually it is pathological as opposed to an artifact. Then the thickness, as we said, it ranges. It depends on now where you're measuring. We said at the insertion point, which is at the thickest, would be 3 to 4 millimeters. So if you find a 6 millimeters, then that is abnormal. And as you move forward, it should be between 1 to 2 millimeters. So if you get a 4 millimeters at the mid portion, then there is still inflammation. But the baseline is none of it at whatever portion should be more than 4 millimeters. Because then that would mean there's some form of inflammation. So the technique is that we've said you place the patient supine or prone, and the ankle should be dorsiflexed so that you're bringing the plantar fascia more superficially. Then the transducer that we use is a linear high frequency probe, but because it has an array, and if you're able to adjust the frequency, you can actually bring it much lower when you're assessing the plantar fascia after assessing the Achilles. So of course, the landmark, where do you get it? Is that its origin is at the medial calcaneal tuberosity. So when you just put your probe there, that is its origin. And most likely, that is where most of the plantar fasciitis is usually seen, because it is where the weight bearing, or when you're running, it is where all the weight is placed. So then we've said that the normal features should be less than or equals to 4 millimeters at worst, and that the echogenic band should be homogeneously echogenic. Homogeneously means it should appear the same all through. If it has any other appearance, then that could be that could actually be a pathology. And as you can see, the common pathology that we get is that we can have plantar fasciitis, which would mean there is thickening of the plantar fascia itself, which is greater than 4 millimeters, and it would appear hypoechoic. Remember, the normal would be hyperechoic. Then we could also have those partial tears or any other kind of inflammation. We even have what is known as the Layden-Horse syndrome for the plantar fascia, where you find there are hypoechoic masses within the plantar fascia itself. But that one is not usually an acute thing. It would be most likely have come as a syndrome, because it is not known, it is chronic actually. Then so what is it that for both the Achilles and the plantar fascia, some of the pathology clues, whenever you want to think about the plantar fascia and the Achilles, the first thing you need to ask yourself is, what is the normal pattern? So the normal pattern is hyperechoic for both of them. Anytime you see anything that is hypoechoic, that would mean, and it is not anisotropy, and we've talked about anisotropy, that would mean they could be tendinopathy, which could either be partial tears, it could be tendinosis, which would appear heterogeneous, or it could even be partial tears, it could be anything. As long as you see anything hypoechoic, then there must be a problem, because what we expect to see for both the Achilles tendon and the plantar fascia is hyperechoic appearance. The next thing that would give you a pathology is if there is discontinuity. Those parallel lines, which we are calling it fibrillar pattern, it should be continuous all the way from where it is starting from to the end, whether it is, and remember, for tendons and even it depends on where you're starting from. If, for example, you're scanning the Achilles and you're starting from the heel going up towards the muscle, then the other one, it becomes now like the origin. The other one becomes insertion. If you're scanning from the top, from the gastrocnemius, and you're moving to the calcaneus, then it becomes you can use origin and attachment interchangeably. So in this case, all we want to see is there continuation? If there is discontinuity, then that could mean there is tear, which could either be partial tear or complete tear. And when there is complete tear, some of the characteristics we will see is that we will see fluid, we will see the tendon has retracted completely from its origin, yeah? And there is fluid associated, because there is no way you will have a full thickness tear without fluid around it that would form, because that detachment is actually a pathology. Then we have hyperemia on Doppler. Hyperemia is when hyperemia is hypervascularity. Yeah, when you put your color there and you see that there is increased vascularity, then it means there could be inflammation. And in this case, it is tendinitis or plantar fasciitis. Tendinosis will be a chronic process, and therefore there will be no flow or minimal flow. And how do you tell what is minimal, what is a lot? It is by comparing with the adjacent leg. Same point, you put your probe there, put your color without adjusting anything. You check the vascularity at that point. Compare with this other one that you're thinking they could be hyperemia. Then it will answer for you because they are supposed to be the same. So those are the pathology clues. We want to check continuation. We want to check the appearance. Yeah. And the clinical, so Achilles tendinopathy, we've said is common in runners, and we've talked about that. Plantar fasciitis is also common in runners and overweight athletes. And ultrasound will usually allow real-time assessment and also guided interventions like PRP injections. And of course, the dynamic assessment. For example, if you want to do, you're not very sure if this tendon is completely torn or not. When you try and do that dorsiflexion maneuver, there will be no movement because it's supposed to be that dynamic maneuvers is what will have to show you that the tendon is moving or not. So if there is no movement, you're not seeing anything, then it means that that tendon could actually be completely retracted. Yeah. Then, so we go on now to the second part of our quiz, which I want us to attempt and try. Yeah, since we have a few minutes left, but yeah, we're almost done. So the first question is, what is the normal sonographic appearance of the plantar fascia at its calcaneal origin? Someone to try?
Let's see.
C, that is hyperechoic and less than 4 millimeters. So that is correct. Now, if there was pathology, what would I expect?
Hypoechoic of more than 6 millimeters, showing that
Yes.
this is an inflammation of some sort.
Exactly. That's good try. And then which structure is found just superficial to the plantar fascia? Someone to try? Which structure is found just superficial to the plantar fascia? Anyone? Okay, so maybe we can go back. Yeah? You can see here. What is this? This would be subcutaneous fat. And of course, very superficial is the skin. Of course, the skin of that sole, and then there is the fat pad. And then below the fat pad, we have the plantar fascia. Below the plantar fascia is where we have the muscles. Remember this image here, we have the flexor digitorum brevis, which would be just below it when you're scanning on sagittal. But when you're scanning on transverse, there are so many. You can see this very thin, where the arrows are. You can see these small arrows. It is actually demarcating where the plantar fascia is on transverse. But above it here is the skin and the subcutaneous tissue. Below the plantar fascia is where we get all the muscles. These are muscles, all of them. The flexor digitorum brevis, the quadratus plantar, and the flexor hallucis longus, all of them are muscles. So just below the plantar fascia is where you see the muscles, and it would have a different appearance. But above it, which is more superficial, is where we have the subcutaneous and the skin. So going back to our question there, I hope you have understood. The structure that is found just superficial to the plantar fascia, that is above it, is the subcutaneous tissue and the skin. The plantaris tendon was not even in the plantar fascia. This tendon is another tendon that is usually just below the Achilles, and it is a variant. Not everybody has it. There are people who have the plantaris tendon and some do not have. And sometimes for those patients who have like the plantaris tendon and they have a full thickness tear of the Achilles, you will sometimes see this and think that it is the remnant of the Achilles because it has the same appearance, but it is very thin. because it's a tendon, it will have that fibrillar pattern and all that, but it will have its continuity all the way from its where it's originating from to its attachment, which sometimes we confuse that it is a remnant of the Achilles. But then also, it is not with every patient. Some people have the plantaris tendon, some do not have. Then we have the Kegas fat pad, and of course we talked about it. It is just below the calcaneal insertion of the Achilles. Below it is where we have what is known as the Kegas fat pad. Then of course the flexor hallucis longus is a tendon that we've talked about, and when you're on transverse, you first see the flexor digitorium brevis, then the one that is more lateral would be the quadratus plantae. Then we have the flexor hallucis longus, which is more deeper. But yeah, over time, you will actually see that they have interfaces. You can be able to tell that this is not continuous with the other one. And you can try that when you're doing your practice. So the answer here is subcutaneous tissue and the skin. So that immediately after, you can be able to see the plantar fascia. And if you're not sure, create an isotropy. And creating an isotropy is angulating your probe so that it appears darker than the rest. Then you can be able to see when you change that angulation, it will also disappear. That darkness will disappear so that you will know that this was actually the plantar fascia. So I can see we have 5 minutes left. Let's do it quick. So we have plantar fasciitis is typically diagnosed in ultrasound when the fascia is, someone to try?
B. I think it's B with more than 4 millimeter and hypoechoic with perifacial fluid.
So I don't know if you can hear me now or...
Oh, I can hear you now.
Yeah, I had to leave and come back. I don't know what disabled the mic, because on my end, the mic was on.
Okay, whenever you have that issue, just leave and come back right away.
Ah, okay. So yeah, we are done. All I was saying is that there's a lot of aspects to MSK ultrasound as opposed to just what we did today, which is the Achilles and the plantar fascia. There is so much that we can be able to cover. Yeah, so thank you so much. Maybe Joseph, you can take up from there.
No, there's nothing really I have to say. Like I said, I just got finished the webinar that I was doing. And just, just need to make sure, does anyone have any questions to Nelly for tonight? I apologize for the technical difficulties. We'll definitely fix those. But any questions for tonight? MSK is rather, I find MSK one of the most difficult things that I try to stay away from it because I don't know it. And I'm of the opinion that if I don't know how to do something and I don't have to do it, let the professionals like Nelly or yourself, who's going to be using MSK, do it. So any questions from you guys? Okay. All right. Well, if there are no questions, let's adjourn for the evening. I forget what's on today's what, Tuesday. I forget what's on the agenda for tomorrow night, Nelly. I haven't looked at the schedule, but let's do the test for tomorrow night before we get on.
Okay.
Okay. All right.
Yeah,
Thank you,
thank you.
guys.
Yeah,
Have a
and
good
thanks for
evening.
participating. Yeah, there was very good participation. Thank you.
Right. No worries. Have a good night, guys.
Thank you.